Hello, everyone. It's great to see so many of you here. Good morning, good afternoon, depending on which part of the world you're listening in from. I would like to give everyone a big welcome from part of the SPR Communications Committee. We are very happy to be hosting yet another webinar. Today, we are very lucky to have Claudi Bockting presenting for us. I am going to tell you a little bit about her, and then I'm going to let her start talking so I don't take up too much time. But today's presentation is called How to Improve Sustainable Effects in Psychotherapy and Why We Have to Zoom Out to Get There. Now, Claudi is a professor of clinical psychology and a licensed clinical psychologist at the psychiatry department of Amsterdam University Medical Centers. And also, together with Professor Reina Weers, she is the director of the Center for Urban Mental Health at the University of Amsterdam. Together with her research team, Claudi focuses on improving interventions for common mental health disorders, such as depression and anxiety. More specifically, her research program focuses on the following topics: understanding etiological and maintenance factors in depression and related common mental health disorders using complex systems approach, developing innovative multimodal psychological interventions combined with technological device and pharmacological treatments, and evaluating the effect in RCTs and micro-RCTs using ecological momentary assessments and effective networks, and also increasing accessibility of effective psychological interventions in low and middle income countries using technology. So, Claudi, it is a huge pleasure to have you presenting for us today. Thank you very much for giving us some of your time. And to everyone in our audience, we are going to have a Q&A time, so be sure to turn on your microphones and ask your questions to Claudi directly. And in the meantime, you can also drop them in the chat box on the lower bar of the Zoom panel. So having said that, thank you very much, Claudi. All yours.
Hello, hello everyone. Thanks a lot for this invitation. It's a little bit of a pity because it would be really nice to see you face to face and to see actually in everyone's face the responses when I say this or that. And I love also the interaction. And we sort of discussed on forehand that I will do a talk with in two parts, and after the first part I also actively will ask for questions or discussion points, and then we go to the next part. Now the title is How to Improve Sustainable Effects of Psychotherapy and Why We Should Zoom Out. And I try to discuss this a bit. Before I do that, of course, this is all the work of many brilliant people, PhD students, postdocs, scientists, practitioners, assistant, associate levels, and some collaborations also with other professors. And I couldn't do this talk without them. I want to discuss currently with you, and many of you are probably completely aware of it, of the current status. So the current status on the prevalence, but also the current status of the evidence and the effects of current treatments. Some issues on sustainability, and maybe also how psychotherapy could play a role in this. Then I come to the next part of this presentation, is why we should zoom out. And I want to discuss some ways that we are trying to zoom out. And then I continue to focus on the more actionable links for interventions as well as policy making. And then the last part, I would like to invite you also to be part of the gang and see what we could do together, maybe to make a change and improve mental health outcomes on a larger scale than only within, for instance, your country. So what's the current status? Probably you are all aware that there is this global burden of disease that makes estimations of mental health conditions throughout the world. So this includes high-income countries, but also low and middle-income countries. And it's already a couple of years ago, before COVID, that the estimation was that 970 million people live with a mental disorder. And when I'm talking about a disorder, I'm talking about mental health problems that result in severe functional impairment. For instance, not being able to take care of your children or bring them to school or make sure that there's some kind of food. This is just an example. So in 2019, 1 out of 8 people lived with a mental disorder, and anxiety and depressive disorder is the most prevalent. Some of you might be the specialist on addictions, and if you include addiction, so substance use disorder, also for instance smoking, then you could argue, okay, addiction, anxiety and depressive disorder and substance use disorders are the most prevalent ones. Now, at the first year of COVID, you probably vividly remember, there was an indication also based on the global burden of disease study that there was a rise of over 25% of the estimate prevalence in the first year of COVID for anxiety disorders and depression. Now we're a bit ahead of it. And we back then said, yeah, listen, if indeed lockdowns and the spreading of the virus has such a big impact on the increase of anxiety and depression, it's important to model this, so to make a bit of a feedback or causal loop diagram of it. Now, we try to do that in a very modest way. And in this model, we say, hey, the prediction is that actually the prevalence rates of anxiety and depression on the long run will go further up, because the best predictor of the future is usually the past. So if you have experienced already anxiety or depression, you have a higher chance to get it again. Although there has been debates on this as well. For instance, Brenda Pennings publishes studies indicating like, oh, now we're fine again. There is no increased prevalence at the moment. It was only a timely effect. There was a sudden increase and then it returned to more normal. My intention now is to give an answer to who is right or wrong. And I think if we are discussing this together, everyone will have a different position. My intention is to indicate that we do know that prevalence of mental health conditions are high, and mental health conditions are not only the result of internal problems, right? And many psychotherapists and who do research on that are convinced by it, but at least we do know that, for instance, something societal as a virus leading to lockdowns evidently had an immediate impact on mental health and mental health conditions. That is clear. The question is, how long does it have an effect? So what's the current status of treatment? If you take it all together, and here I cite the work of others that actually try to make an estimate of the effects of current treatments, you sort of find that 50% of the people, roughly estimated, do have a good response on our current treatments. And this is not only reflects psychotherapy, but also all kind of other more biological, neurobiological treatments. Most of the treatments target the individual, for instance, psychotherapy with an individual, or say, for instance, a specific medication for an individual, and some include also the family. I know there are also all kind of interventions that, for instance, try to target the school, but that is something we talk about later on. There is a little bit of a problem because we do not find strong indications that the effect sizes of, in this case, psychotherapy, but also of other kind of treatments, for instance, specific medication, increased. Even more so, for instance, in children and adolescents, we actually see an indication of the decrease of effect sizes of treatments. So does it mean that everything that we tried to do in the past, say, 40 years didn't make any sense? No. There are, of course, a lot of new treatments that have been developed, also in psychotherapy, and that's clearly resulted in an enlargement of the supermarket. For instance, we do know that digital interventions with some kind of guidance help. They are effective. So there's something to choose. We do have more knowledge that if someone has, for instance, a depression, that there are different types of psychotherapy that are actually as effective. Now, that's important as well, because then there is something to choose. We do have transcranial external stimulation of the brain. There seems to be good work going on with promising effects. But the problem is the new treatments are not more effective than the old ones. Or they are, and the people who do not respond to treatments, so the more treatment-resistant groups, there are no indications that we can serve them better. This is a bit of a rough statement. There are some very small groups that we do have a better prospect for, but these are not the biggest. It's not a very big group. So overall, you could say the current status is we do have effective treatments. If you go into the field of medicine and you can declare that 50% of the people have a good response, they say, whoa, you really have gold in your hands. So it's something to be proud about. And by the way, this is not only pre-post, but this is also compared to all kind of control groups. So that's something to be proud about. But there's no indication of an increase of the effect of treatment, whereas there is a lot of development in the field. And then there's the problem of relapse. We now more and more know that not only depression, but also, for instance, many anxiety disorders often recur. And also, unfortunately, this is not only the case when you're 50 or 60, but also in young people. So young people between 13 and 25 years old. There you find already a prevalence rate of relapse in depression in 2 years of 50%. And for anxiety disorders, 50% of the young individuals have a relapse in an anxiety disorder as well, but this is in 4 years. So it's not relapse is not only a problem in a specific condition. It is a problem in common mental health conditions, and for instance, if you're working on substance use disorder, what is the main problem there? Not to get people clean, but to make sure that there is no relapse. Okay, if you give me one moment, because there it is. So already a long time ago, it was in 1990, I thought, what if we start psychotherapy after remission? Because when people are feeling very well, they also have a very good way of reflecting. They have less cognitive functional problems, less problems with concentration and so on. Could this be an approach that might contribute to better relapse prevention? And this back then we developed specifically for people who already had recurrent episodes of unipolar depression. And it starts after remission, only includes 8 sessions of psychotherapy. And it focuses, actually on 4 key ingredients. One is working on rigid belief and schema. And this is specifically done by activating a positive network. So using positive images, fantasy, and experiential techniques. And the reason why I chose to do that was because I thought maybe people don't want to start psychotherapy when they are doing well after a long time of multiple episodes of depression. I thought I need to select techniques that are actually more attractive. Now we have a lot of more evidence actually clearly indicating that if you use positive imagery and positive affect, that this might be a very promising technique to result in sustainable effects. But this was just an old technique demonstrated a long time ago by Christine Padesky. But that's what we did. And if you're more specialized in CBT, we call it over there challenging techniques. But we use these positive imagery and positive experiences. We also worked on stimulating to have a better recall and encoding of specific positive autobiographic memories. And this we did because we knew in recurrent depression there is a higher level of overgeneral autobiographic memories, and this is associated with poor problem solving, but also with poor emotion regulation. And this is for negative and positive experiences, but I want to especially train to have a better recall and encoding of positive experiences, positive thinking, and also positive feeling. So that was trained by using a relatively simply daily record or daily, a daily record. And for everyone, a personalized formulation of relapse prevention plan was formulated. And this was actually the result of the psychotherapy in the sessions before. We just discussed this. This is we did a couple of trials on this, but this is all written down in a treatment manual. It's available in Spanish and also in the Netherlands, and now on the review at Guildford, so it will probably be soon available as well in English. And if you're interested before, I'm happy to share it. Okay, let me just yes. So of course, then you want to know what's the evidence. So the first trial, we added this on top of treatment as usual in recurrently depressed people. And they got 8 sessions, so after remission of preventive cognitive therapy, randomly, and the control group only got treatment as usual, and treatment as usual was most of the time no treatment. For half of the people, it was continuation of antidepressants, and for I think it was 25% or so, it was some kind of continuation, or 30% continuation of psychotherapy, so like booster sessions. We monitored everything. Our main outcome was time to relapse back then over 2 years. But in the meantime, we also did a follow-up at 3 years, 10 years, and now also at 20 years. So we examined, so if you have had randomly 8 sessions of preventive cognitive therapy on top of treatment as usual 20 years ago versus just treatment as usual, what is the impact on time to relapse? Now, over 2, 3, 5.5, 10, and 20 years, we found that it had a significant effect in delaying the time to relapse. We also found, for instance, over 20 years, that it halved the number of relapses. So if you have had 8 sessions, the people who received 8 sessions of preventive CT in 8 weeks had their relapse, the number of relapses halved. We also saw in the first 2 years and 3 years also an effect on the severity of relapse. So if you have a relapse, it's less severe. But most importantly, we only saw this significant effect for people starting from 3 or more. So for the people who only had 1 or who only had 2 episodes in the past, we didn't find an effect. Now I have more and more evidence that this might be a time effect. You simply have more risk of relapse if you have more episodes. But I think it's still interesting to think about this. And to make it a bit more concrete, at our 20-year follow-up, we detected that for the people who got preventive cognitive therapy, the time to relapse was almost 5 years, 4.8 years, versus for those who didn't get it, it was 1.6 years. And to be honest, one of the scientist petitioners here who Amanda Legema, wanted to do this follow-up, and I thought 20 years, I don't know, what else can it tell us what we already know? But she insisted to do that. And I had to admit that I think that was very important, because you can understand that in a life, it really makes a difference when you have like a relapse, a depressive relapse, so a depressive episode once every 1.5 years, it really, versus almost 5 years, it can really make a difference. It can be the difference between, for instance, being able to have a stable relationship, or even to finalize your exam, or to be able to have the right to get back and work again. Because we also do know that many people with these recurrent episodes often lose their jobs because of the recurrency. So this was sort of promising, but yeah, you still have to see, could we also do it in a different way? The prevalence is very high, so we developed a self-help version for primary care. It's called Between Dip and Dream. And this was studied also in a randomized control trial in primary care, so with general practitioners. And in the Netherlands, they have nurse practitioners, sort of nurse practitioners, and they supported this self-help. So people got a book, and the nurse practitioner also, and they supported it. So they discussed, okay, did you manage to work on it? Were there any things you didn't recognize, and so on. And we examined over a year whether this would be effective. And we found that it indeed significantly reduced the risk of relapse and increased the quality of life in those who had have a depression before. In this study, it was for everyone, not only for those who have at least 3 or more episodes. And it was a small to medium effect. So that's interesting. What we also wanted to do is to see what if people already got cognitive behavioral therapy during the acute treatment. Because many people get psychotherapy. Why did we choose cognitive behavioral therapy? Because there was already a study from a colleague, Robin Jarrett, that demonstrated that if people have during the acute phase cognitive behavioral therapy, they have lower relapse risk after they stop, after they are remitted on it. So we thought, could this be an add-on after having responded to cognitive behavioral therapy? This was studied also in a randomized controlled trial with Margot de Jonge, who did incredible work on this. And there we found that even if you already have cognitive behavioral therapy, that 8 weeks and 8 sessions of preventive CT had a medium effect in reducing and delaying the time to relapse, and also of some of the secondary. So even after this type of psychotherapy, we also examined what if you deliver it via an automatized intervention, and that was supported, also guided by a licensed psychologist. It took us 3 years to build an attractive automatized intervention. Now, we can talk about this for an hour by itself, but I can already say to you it was not effective. It only had an effect over 3 months, but not on our main outcome, and that was time to relapse over 24 months. So the effect was only temporary or not sustainable. So I wouldn't recommend that, at least not the way we did it. So then, I hope you're still with me. We, of course, wanted to know, could it be an alternative to using antidepressants? Because the majority of people in the world use antidepressants to prevent relapse. That's just what happens the most. So can I stop it? This was literally a question of a patient of mine. Or there was another patient. Does it make sense to add it to continuation of antidepressants? And I had no answer to it because we did not systematically and controlled study it. So that's what we did. I cannot recommend you to do such a study, a 3-arm study. It took a long time and many incredibly gifted PhD students to finalize this study. Hermine Elgersma, Christine Slofstra, and of course also Gerrit van Rijsbergen and Nicola Klein, who supported us on this, to do this study, to actually randomly examine what if you just randomly assign people to continuation of antidepressants versus guidance with tapering and preventive CT, so stopping the antidepressants, versus continue with the pills and get preventive CT. These are the results. Yeah, we actually saw, to our surprise, that people that continue antidepressants, this is the green line in the bottom, and get preventive cognitive therapy do the best. That's superior. Their relapse risk is reduced with 41%, and that's a big effect size. So they do the best. They have the lowest risk of relapse. But we also saw, because we compare 3 arms, right? That those that continue antidepressants versus those that taper antidepressants and get preventive CT, they are actually doing in a comparable way. The lines almost cross. There is no significant difference to those that stop antidepressants and get preventive CT versus those that continue antidepressants. If you look closely, you see in the first 4 or 5 months that actually when you stop antidepressants and you get preventive cognitive therapy, you do a bit worse. There's a little bit more relapse, right? But we found out, our primary outcome was time to relapse over 2 years, that this effect of tapering antidepressants is only temporary. If they stick to the program, then in the end, it's comparable. So using antidepressants for relapse prevention is not superior to tapering it plus this brief psychological intervention for only 8 weeks. Okay. Now, I forgot to say that it also has a positive effect on the number of relapses. Now, it's a lot of details. It's important to realize we also have an alternative way of preventing relapse, and prevention is per definition, it's crucial to have sustainable effects. You're probably aware of mindfulness-based cognitive therapy. Also for mindfulness cognitive therapy, they found that it could be an alternative for continuation of antidepressants. So this holds for preventive cognitive therapy, but also for mindfulness-based cognitive therapy. But if you add it on top of antidepressants, we only see an effect for preventive cognitive therapy and not for mindfulness. They also studied that in the team of Speckens. So for now, we see a differential effect with a method. We just have to wait and see. Okay. Oh, let's see. Now, I think this is already discussed. So in a way, you could say people can stop, if people really insist on stopping antidepressants or tapering it, we do have alternatives. But be aware, the combination of continuation of antidepressants plus preventive CT is really superior. So, yeah. Now, and this all now also have been confirmed by meta-analysis, and recently there have also been published 2 individual patient data meta-analysis supporting sort of the same things. Let's see, hopefully that's in my slide. Yeah, so that exam that we brought together all individual data of all studies that have been done on relapse prevention. And everyone who was able to deliver these individual data, we examined actually what works for whom. That's called an individual participant data meta-analysis. Then you have more power because you have all these individual data to explore what works for whom. Now, there we found out actually that continuation of antidepressants sort of has the same effects as preventive cognitive therapy and mindfulness-based cognitive therapy. But we also found no individual indicators, for instance, that you can better continue antidepressants if someone already have very severe depressions, or if this person has comorbidity on, for instance, personality, or if the last episode was very severe. We saw no indication that it's better to do one or the other, depending on the individual characteristics. So what does this mean? People have really something to choose. Yeah. But this is not the case if you combine it with continuation of antidepressants. Then clearly preventive CT does till now better. Okay, this is of course a lot of information. What we recently also did is to examine, okay, we zoom into the individual and try to find out using apps what is actually changing, what is going on in the daily life. And with these apps, you can ask, for instance, for mood, for affect, for emotions. And then you can create these figures. Many of you are probably aware of it. And this is to the left, you see one patient that actually was tapering antidepressants. And so it's one patient at one point, and there at this point, for a week or so, this person was indicating at several moments a day how this person was feeling. And then you can examine, okay, what are the partial correlations between, for instance, specific feelings. For instance, between being irritated and sadness. So if you're irritated, you get even more irritated, but you also get more sad, for instance. And you can do this at several time points. And what we did recently is to examine, could it be the case that if you are tapering antidepressants and you get this type of psychotherapy, that this structure, that your emotion regulation and how this actually interacts with all kind of things in your life change in a different way than when you're continuing antidepressants. And why are we doing that? It's actually to get a bit more mechanistic insight. And more importantly, we also want to examine, does this also lead, what kind of changes are crucial to have more sustainable effects of these type of interventions? Now, I have it not in my, but we recently actually published this. And the first author was my PhD student, Eunice van der Wal. And what was interesting is actually we couldn't make any chocolate out of it. And that is that these daily fluctuations in feelings, avoidance, and so on, were not predictive of relapse, but also there was no differential change. So if you, for instance, only use antidepressants, we saw not different patterns than, for instance, when you get psychotherapy and you stop the antidepressants. And for the fun of it, we also compared it to healthy controls. And there we found, comparable changes. So what does it tell us? Now, it tells us that there's a lot more research that we need to do to examine whether this can really bring us something in clinical practice. Okay, after this slide, I'm going to get back to you to have a sort of an in-between check whether there are questions and hopefully some answers. So sustainable effects, do we have sustainable effects? This is just an example of sustainable effects. We do see, and this is just a specific one, but that even short-term psychotherapy can have long-term sustainable effects. For instance, after treatment as usual, on top of treatment up to 20 years for those who have more than 3 episodes. We also see sustainable effects over 2 years after, in this case, a specific type of psychotherapy. We do see that if you add it on top of antidepressants over 2 years, it considerably reduces risk of relapse with 41%. In primary care over 1 year, we see that a self-help version that is supported by actually relatively non-specialized people are effective, also for people who only have 1 episode. And interestingly, it could be an alternative for those individuals who really want to stop, and who really decided or insisted or even are pregnant and think, no, I don't want to use it. Then preventive cognitive therapy or mindfulness-based cognitive therapy can have a sustainable preventive effect. And unfortunately, we see no convincing effect of automatized internet intervention, in this case, the one we studied. So we don't offer it. So it's a lot of talk. And what I would like to ask for is whether yeah, there are questions.
If anyone has any questions, you can turn on your microphone to ask them directly, or you can type them in the chat box. Igor, yes, go ahead.
Hi, Claudi.
Hey.
Thanks for this first part of very interesting talk. I'm wondering about your about the subjective appraisal of the lifestyle of these patients. I mean, do those patients that profit more from interventions such as cognitive or mindfulness-based cognitive therapy, are these patients those who have more issues with their own perspective about their life, or these treatments are effective independently from their own perspective about the future?
And so it's the perspective on the future?
I mean, are these treatments that you showed are so effective? And I fully agree. Our scientific hypotheses are based on the same framework, so I fully share your perspective. But I'm wondering whether these treatments that you suggest as highly effective depend also on the quality of the perspective each patient has. My guess would be that those patients that have a very negative outlook of their own life might benefit more from these interventions compared to those who have already a very positive outlook about what they will do in the future, about what they do in their life.
Yeah, now it's a very good and valid question. And actually, to sort this out, the best way would be to also include all kind of qualitative interviews, right? And that we didn't do. So we simply do not know, but we did assess, for instance, cognitive beliefs. And these cognitive beliefs are about themselves, others, and the future. And on that perspective, we didn't find that it predicted what works for whom. But nevertheless, it's different if you ask this in a questionnaire versus where it would be very interesting to examine this more in qualitative research, right? And that we didn't do. So, but overall, we found actually no indicator at all that, for instance, pills are more better when it comes to sustainable effects versus a psychotherapy like mindfulness or preventive cognitive therapy. For now, all the factors, there's nothing there. It seems to do the work for everyone, but this one we don't know for sure. But I think it would be very interesting to explore that.
Thank you very much.
Denise, you have a question as well?
Yes, a comment. Well, thank you, Claudi. Very interesting presentation and method. And I think that this presentation brings close some issues which are not so present in SPR presentations or webinars. So that's for you, Juan Cruz. One is supportive therapy. We very seldom have activities on supportive therapy, and in fact, it ends up being the most frequently used by young therapists, and they do anything. So we need more evidence, I mean, more dissemination of evidence about the use, misuse, and effects and counter effects. First. Second, pregnancy. I think you mentioned this is a good resource when pregnant women want to stop pills. And again, we have few webinars on pregnancy and psychotherapy and I feel like a mother doing this on you, Juan Cruz, but the age difference allows it. And no, and the third comment is that this is in connection with the concept of intermittent psychotherapy along the lifespan, which is very interesting, has very little been very little explored, and it brings up the issue of termination, because traditionally termination is wow, the end, and especially in the psychodynamic tradition. And actually, there are other ways to end up one form of therapeutic relation and continue in other forms like this, or intermittent life, or the model we have of family doctor being transferred to sort of bedside, I don't know how to say it in English, terapeuta de cabecera, the therapist whom you go back in different moments of your life, who knows you perhaps for one session or to ask a question about a son, a child. So I think that these are issues which are in connection and maybe useful to explore. Thank you.
Thank you very much. Yeah, I couldn't agree more. We actually did a proof of pilot study, randomized controlled trial in pregnant women that use antidepressants to prevent relapse. And we examined the effect of tapering antidepressants, giving them PCT on themselves, but also on their babies. We found no indications that it would be harmful for the mother or the baby. So I think this is very hard to do these type of studies, but I cannot agree more. This is something we definitely should put more effort on to study this internationally. And yeah, I think also when we do treatment indications, so I worked a lot with depression, I think we have to take, half of the people take antidepressants for a long time. And so if you do treatment indication, and this is someone that still maybe later on might have a baby, so a woman usually, then it might make sense to take into consideration that these are the facts. So 50% of the people take antidepressants long, so we have to take this in consideration. On the supportive therapy, I do agree. I'm also in the interdisciplinary guideline committee on depression, and there again we dived into the evidence for supportive therapy. On relapse prevention, we examined this in the first study. The treatment as usual sometimes was boostering with supportive therapy. And we actually, interestingly, we found no convincing effects of any kind, not only supportive, any kind of booster sessions that aim to sort of prevent relapse. So people who actually got any kind of support in psychotherapy or medication or whatever in mental health care, they actually didn't do better than those who did not. This doesn't prove that it makes no sense. It's just we need more studies on this. Okay, I think it's best now I continue to the second part. I see yes, okay. So why should we zoom out and how? Now, yeah, this is actually partly already discussed, like still 50% of the people roughly do not respond. The relapse rates are still high. Also, preventive cognitive therapy and mindfulness, it's not bulletproof. Still a lot of people relapse, right? And we have the problem with accessibility, yes? So, of course, we think we are with a lot of, but the prevalence of mental health conditions is like gigantic. We are not enough. We simply have not enough people to make sure that they get it. One other perspective is actually look at the mental health condition as a complex system. And this has been done a lot. Like many people now are sort of embracing, like, okay, you cannot compare a mental health condition to a specific medical condition, like for instance, COVID. Yeah, it's caused by a virus, right? We cannot say, okay, there is a single cause for mental health conditions. Usually we define it by symptoms, and we do know that symptoms trigger other symptoms. If you don't sleep well, you might have concentration problem and you get sad, and before you know it, you think of yourself, I'm not a likable person. We also know many people embrace at least that it's a result of the dynamics of inside, neurobiological things, but also psychological things, but also the environment. think of COVID and the restrictions, for instance. And we have this issue that actually the symptomatology, but also these mechanisms change over time. If you, for instance, if you feel sad, then therefore you get more negative beliefs. Whereas if you assess beliefs before people are sad, you get a different outcome. If you assess cortisol levels before people are sad, you get a different level than after they already are sad. So that means it also changes over time. And in complex systems, they like these kind of things. They think, yeah, you know, of course, things are changing all the time. It's like a dancing system. Now, and there are some people who did a lot of work on it. And I know some of you that I see now very small in my screen actually did also excellent work on this. So please don't feel like, I don't want to cite your work, but for instance, Danny Bosboom did a lot on the studying mental health problems as a network of symptoms, but also mechanisms. Angelique Kramer, Eiko Fried, also Laura Brinkman. In the past, it also has been studied by ecologists. And they studied this in a way that to find out why are so many fishes dying in a shallow lake. And by studying this with a complex system approach, they found out that a simple intervention might prevent it. It also has been used to study criminal networks. So, for instance, many policymakers think, and the police think, what we have to do if there's a criminal network, you have to wait till you can catch the Don Corleone, the mafia boss, right? And they found out if you do that, it will be replaced by another network that is more aggressive than was out there. Whereas if you study the network, the best thing you can do is actually try to find, target the man on the street. And do you know what the man on the street is? It turned out to be the electrician. The electrician is hard to replace in a mafia network. And if you take the electrician out, then it is not replaced by a more aggressive network. The network falls apart. So these are very interesting perspectives that might also be of relevance if you think about new ways of finding new target points for interventions. Now, you could say such a network could be a symptom, but a network could also be the environment. For instance, the people that you are in contact with, or even the city where you work in, or the neighborhood, or even the country where you work with. And what I try to say is that maybe if we zoom in, focus on the individual, but also zoom out again with maybe some of the science approaches that have been used elsewhere, maybe we get a different perspective on what target point for interventions are that are actually more sustainable. And this is, of course, something you can do, but then we need to reach out as well to other disciplines. And I know many people in SPR take this step now, so that's really exciting. And important to realize, soon the majority of the people live in urban settings. And we did a study on the association between the prevalence of mental health conditions, and this was anxiety, depressive, and substance use disorders, and the level to which a country was urban. And we found out that especially in countries where over 50 to 60% of the people live in urban environments, you see a steep association with more anxiety disorders, more depression, and more substance use disorder. So what does this say? It gives us an indication that we also need to zoom out a bit and explore a bit more the living conditions. And apparently living in a city or urban settings do have an effect not only on minor stress levels, but also on mental health conditions. And this is problematic, but might also be a target point. And I just want to give you a bit of an example of something we try to do. It's a very modest attempt. It has been published in Lancet Psychiatry, but I'm certainly not claiming that this is a theoretical framework. It's only a first framework in which we try to zoom out and examine how, for instance, individual factors feed into symptomatology, but also how social factors, for instance, neighborhood low social cohesion, feed into individual factors, but also urban factors like living near the highway, for instance, constantly have some kind of noise at the back. And what we try to do there is to make a theoretical framework that we now also do simulations on with data in how to, actually examine how all these factors contribute as feedback loops to each other. And our main aim is actually to find new target points. Now, and how could we maybe find new target points, not only for interventions, but also policy making? Now, one example could be on macro level, on societal level. Now, this is just an example. I'm not saying this is the way. We are just attempting some things, and this is what I do together with our interdisciplinary Center for Urban Mental Health. We are now, for instance, at the moment studying what are the effects of public health campaigns that are trying to stimulate people to talk to each other and when they have mental health problems. So they simply try to stimulate people, hey, if you have a problem, talk to someone about it. So we're going to examine, okay, what's the effect? Does this actually happen? Are people actually on societal level more resilient? And do we find an effect on their social network? And at the same time, we examine within the ultra high risk individuals, what happens if this is combined with, for instance, specific interventions, for instance, psychotherapy? Do you then find with this multi-level approach a better effect than when you only target the individual? This is just an example, but also within the individual, for instance, we also examine what if people get external brain stimulation. This is done with magnets, and at the same time get psychotherapy. It's a completely different mechanism that you target. If you do it at the same time, do you find more sustainable effects than if you, for instance, only give psychotherapy? These are just some things we are playing with, and we also have some models to test this. And of course, this is constructed together with the people actually who are giving all kind of input. So people with lived experience, with patients, and also with therapists. Another macro level intervention could be, for instance, examining the effect of economic crisis. So this is a feedback loop that we make. And for what if you would target, we do know people that there's a prevalence of mental health conditions clearly go up with economic crisis and also suicide. So then what if you, for instance, would target the association between the cost of living between debts and the cost of living? What if you could target the cost of living? Could you thereby maybe prevent these debts and maybe thereby decrease stress levels and have a lower prevalence of depression? This is just an example. And funny enough, during the start of the war between Ukraine and Russia, the prices of the gas in the Netherlands were extremely high. And there was a lot of stress for people because they were not sure whether they would be able to pay it. What our government actually said, okay, what we're going to do, we will make sure we cover you, we have your back if the costs are higher than this amount. So that means that you know for sure you have to cover this kind of money, but the rest we will cover for you. Now, this is a policy measure, and what we now want to do is actually test whether this indeed decreases stress levels and debts and so on, and indeed has an impact on the prevalence of common mental health conditions. This is just an example. Now, I'm going to explain it. Another way of a sort of a macro intervention is actually use the internet, right? Right, like the whole world is on the internet, also in low and middle income countries. So what if we try to use these digital interventions that actually also have been proven to be effective, and let them guide by people that are less specialized, even lay guidance. Now, we did some work on that, and actually we found even in depressive disorder already a first indication that this actually has a positive effect on not symptomatology only, but even on remission. So these are examples of macro scale interventions that might have an impact. Now, of course, if you're clinically trained enough, you know you will not be able to help everyone. You still need scaling up for those who do not respond. So another example, not on macro level, of group level, and this is something I worked on with Josephine Breedvelt and funded by the Wellcome Trust, is to see, like, what if we could directly target improving social cohesion in the neighborhood, especially in young people? Would it be possible, for instance, hereby to prevent the onset of anxiety and depression? And maybe many of you think, oh, that does make sense, right? But there are actually no control studies that examine this. And I think it might be very interesting to do this and to think of, okay, for whom it might be best to combine this with individual approaches. So this is another example of zooming out. And I think that we have a lot of knowledge to offer because we do know a lot about loneliness, social cohesion, interventions, and so on. And of course, on individual level, we also need to improve, right? And one of the things that helps, one of the things that are ongoing, and I'm surely not the first one in it, is actually, instead of targeting sort group models of etiological models of depression, for instance, or anxiety, we are now able to make individual networks or an individual model. And this is an example of an individual that actually for a couple of weeks assessed during the day how this person was feeling, whether this person was avoiding things, experiencing stressful things. And this is a network of one person. And when it's green, it means that there is a positive association. So when there's a green, for instance, when you're more sad, you feel more anxious. When you're more anxious, you feel more sad. When you have positive feelings, it's a negative association, you're less tired. So this is how you have to read it. Now, what we do, we make for each individual an individual network. It's automatically done. And based on that, the prior diagnosis and some other information, they automatically are assigned to a supermarket of all kinds of intervention, and each intervention targets a different mechanism. For instance, exposure for someone who is avoiding a lot and anxious, and response prevention, or increasing positive effect, or sleep. So every individual gets a different type of intervention based on this individual network. Now, we're a wait and see. This is a randomized control trial because we want to know, this is for young people, whether this indeed improves the outcome for relapse prevention. I don't know yet. Still, I think we now included over 200 individuals that previously had anxiety disorder and or depression, but we still need a little bit more, 40 more to go, and then we can tell you a bit about the results. This is just to show, like, these are some routes that we try to take to see whether we can improve the outcomes by using a specific method to personalize interventions. Okay, so a lot of talk. What could you do? And you can fully disagree with me. A couple of years ago, there was this reporter on the New York Times that actually said goodbye to New York Times, and he reported many, many times on mental health research. And then I read this article of him saying science plays the long game, but people have mental issues now. And I thought this is maybe the core of what we should work on. I know there are many interesting routes to discuss and to do research on. And I'm a strong believer of more fundamental research as well. But I also think I think we have a lot to offer and we have a lot of knowledge. And I think we have to group together with all kind of disciplines to really make a difference for so many people that have mental health issues now. So, and that brings me to you. I think it might be good that we also engage a bit more to face the societal challenges, moved towards sustainable effects instead of only short-term effects. I think we need other disciplines to make a change. And that's why we also started a sort of a European organization for nuclear research, but then for mental health sciences. And our main aim is to actually improve mental health outcomes by bringing all this interdisciplinary research together. This is recently launched, and our main goal is actually to get people together and to see if we can get to more than temporary funding. It needs to be also sustainable funding to make a change for those that are suffering. And this is it's an international center. It's not of no one. But I would invite you to see whether you would be interested or have ideas to actually get together and go for sustainable funding. And the interesting part that this also now is supported by the European Academy of Science and Arts. So that's completely not psychology or psychotherapy or psychiatry or whatever. And also the European Association of Clinical Psychology. And I would like to welcome you if you have any ideas how we could make a step further for sustainable funding. Please contact me on this. Step in, spread the message, especially if you have ideas how to get sustainable funding for everyone. So now I'm talking about university, ministries, international organization, European Union. If you have a direct contact to Biden or whatever, please contact me. Okay, I think this is a bit of promotion for this center that actually is meant to be for everyone. But most importantly, I would like to thank you for your attention, and I'm looking forward for your to your questions. Let's see. Do I need to say something or do something? I see some.
No, Claudi, this has been a great presentation. Actually, we have a question in the chat box from a couple of minutes ago. That it's a question from Rachel. She asked, oh, I can't find it in the text anymore. But the question was in regards to if you were using a positive psychology or symptom-based intervention, since it was a preventive therapy.
Sorry, I don't understand the last part.
Rachel, if you're here, the question was deleted from the chat box, but it was asking if it was.
Hi, I'm still here.
Oh, Rachel, that's
hello.
great.
Yeah.
I was just wondering with the first part of the presentation,
Yeah.
about the preventive therapy, if you're using aspects of positive psychology or if you're just purely basing it on maladaptive thinking patterns and symptoms.
Yeah. No, it focuses on three ingredients. The first one is on the underlying belief in schema, but we don't use positive psychology, but we use positive imagery and an enhancement of positive affect to do the challenging work. but it's challenging of the beliefs and schema. Yeah, but also we actively do a trainer of better recall and encoding of positive experiences, thoughts. So the specificity. Now I can never say that word. I'm very sorry. The specific encoding of positive feelings, positive thinking, and positive experiences. So this is just a sort of a brain trainer. And the last part is that it all comes together. Yeah, so does this answer your question? Yeah. And it's not symptom oriented, because the clue when you're recovered is there are not a lot of symptoms there, right? Because you're doing good. Yeah, now I see your face, you're right. Many people do have some kind of symptoms. Actually, we're now testing this out in people with partial remission. And that's sort of 20-30% of the full population, for instance, with depression. So I agree with you. It's not that there's no symptom at all, but there's not a lot to focus on. Yeah. Thanks.
Claudi, I have a personal question. If we still have a couple more minutes, I was wondering on what's your way of considering depression. Do you consider the depression yes, depression no, or is there more a gradual low depression, mild, severe? And if so, if severity was somehow related to relapse values?
Yeah. So if baseline severity predicted relapse.
Yes.
Yes. Yes. So we actually assessed all kind of definition of depressive symptomatology and depression. So including the more gradual, so the continuous one, but also the more yes, no. No, we didn't find in our projects that severity predicted relapse, but sometimes it has been reported. It's a bit of an inconsistent predictor. And then my take on this, so is it the case that everyone, for instance, when you're 17 and you have a bit of depressive symptomatology without being depressed, do you indeed have a big chance that you later on will get a severe depression and maybe hospitalized? I have very good news. I think that there's enough evidence that we really have to differentiate in this a bit. We have relatively good predictors at the moment who might have later on a more severe course versus, just in time, sometimes that you simply are, not feeling too well. So I think that part is not completely continuous. I'm here in the clinic. I also see patients. And I do think that the people with very severe depression are not completely the same as the students that we are, for instance, test at psychology that are a little bit higher on some self-report assessments. So, but nevertheless, there is also a very big group where it is a continuum. Hopefully this answers your question.
Yes, that is very, very interesting. Thank you, Claudia.
Yeah.
Now, perhaps one very short last question from Denise.
A comment. I would like to comment on the second part, considering zooming out. And I can't avoid recalling something I heard in the Netherlands presentation in a hospital by Doctors Without Frontiers, in which they were trying to find money to buy antidepressants for the Malawi population in Africa, where they found 90% depression. Malawi has the highest rate of poverty, of maternal death, and of infant death. And that's why you say, do they need depressants or do they need social health? So I'd like to emphasize this, that we should not oversize the psychopathology when the social problems, would you say anybody is not depressed in Gaza today? They are not depressed, they have a real problem. And I recall Frantz Fanon, who was a psychiatrist in the Caribbean, and he's the He was the inspiration for all the revolutionary movements in the 60s. And he said that real therapy is making the revolution, in the sense that there is a limit to our action and within mental health interventions. And there is, I think, a humbler position saying, well, this has to do with a system which makes people ill. He was the first to present this idea that you may be ill not only because of a personal family history, but also of your social conditions. He referred to slaves or to black, I would say black intentionally population in the Caribbean.
Yeah, I couldn't agree more. There's actually quite some evidence. For instance, in Brazil, they did a great study on cash transfer. So actually on the specific conditions, give some kind of basic income, and they found very convincing effects, for instance, on the reduction of suicide. So yeah, I think this is a marvelous example why it's so important to also zoom out. Yeah. Okay, thanks a lot. It's a pity we don't see in person and that we don't have drinks now, and I could actually get to know you all. I want to thank you for the great comments and questions. Maybe sometimes I was a bit too provoking, but I hope to see you at a moment, maybe in the coming year or so, and you find out that I'm actually far more academic than I came across in this last hour. Thank you very much.
Thank you very much.
Thank you very much, Claudi. And to everyone, I've left the links to the SPR webpage where you will be able to find the recording for this event and find out about many more events coming up in this month as well. Claudi, thank you very much. And thank you to all our audience. Bye-bye.
Thank you very much. Bye-bye. Thank you, Juan.